I ask the patient maybe what's their resting pain. So I get a bit of a understanding what happens with movement. Okay. So I get you to flex forward for me. So you can observe, and so is it pain, or is it stiffness, or maybe there is no pain or stiffness. If a patient got full range of motion and no pain, what I could do, I can block the pelvis and apply a bit of an overpressure if it's no pain. And then say, okay, flexion is not associated with patient's pain. But of course, if there is pain through range, I would not apply overpressure, okay? So just go to here, okay, let's go one more time, flexion. I said, oh, that's my pain. So I can take the note how far he's gone, you know, maybe above patella, maybe medial joint, like along the joint line of the knee, and I'll bring it back there, okay? Now for extension, I get to place your arms across the chest and come into extension for me. Again, I'm not going to give him a lot of guidance. I'm just saying show the movement that hurts. I'll look at that range, but also is that painful? And go into extension again, and he's got pretty good movement. So he's got hip contribution and lumbar contribution. Typically, I don't apply overpressure in extension. I think it's enough stress anyway that lumbar is put through. So typically, I do not do that. But you may choose in some cases coming to extension, especially when we look at the neural or quadrant test, then you can apply a bit of an overpressure, but typically I don't do that. Okay, so flexion extension is for side bending, so maybe face that way. Now side bend to the right, good. Look how far he's gone, and look, that's a lovely, nice sort of line, so you can see he's got movement, nice movement along the spine with no kind of deviation, and then other side, good. And this again looks pretty nice movement in the lumbar spine. Again, primarily, you can look at the quality, but I look at the pain. Is that painful? Now, what we want to know, so if you side bend here to the side, if it's painful more here, so hypothesis could be there's a localized pain, maybe a bit of facet. But if the pain is on contralateral side, that could be muscle, isn't it? Yes. You're also putting the length on the muscle, such as QL and even the rectus spine as well. So again, so we're looking, is it more the stretching pain or is it more compression pain? Okay, so remember to sensitize nociceptors, we either by stretching something, maybe compressing something. So we're looking at those movements. And then also what you could do, place your arms across the chest, maybe sometimes it's difficult for them. So if we can do, instead of side bending, side gliding. So side gliding one way, and also side gliding either. So they say also with side gliding, you could maybe differentiate, is it more the jointy, is it more muscular? Because when you side glide, it's less effect on the muscle, isn't it? Compared to side bending. Can you see that? So, I'm super stressed, and then you go side glide. Is there pain or no pain? Or side bending. It's a different movement, but if you want to maybe be a bit more confident, you think, okay, this is a jointy. Let's say pain with this, that's compression, but also with side glide as well, you're going to put load on the spine, so maybe it's joint, but again, we need to do more testing. Now, for rotation, I typically do that in sitting. Let's say if a patient's got pain in a sort of lumbar thoracic with rotational movements, I'll just show you. So get a patient in sitting. I mean, in standing is a bit more difficult. Then maybe what we'll do, we'll sit this way like that. Okay, and then I'll get you to turn one way or the other. Okay. So patient is sitting, arms across the chest. So what I do, I stabilize the patient pelvis. I get him to rotate, let's say, to one side and the other side as well. So I ask that if that's painful. If he said, when I'm blocking the pelvis and it's less pain, it could be lumbar. But if I'm blocking pelvis, so it's no movement in the lumbar, and the patient said, no, I still get pain, that's more thoracic, isn't it? So again, it's not definite. We still need to, palpate, do some physiological movements. But I think it's kind of nice to do that. So you're kind of blocking the pelvis. So no rotation in the lumbar, you're getting more rotation thoracic. And you can try on each other and see how you feel. Because when you do this way, one more time, and so just do general, so you see when the hips move and the knees, is everything moving, isn't it? Yeah. But when I'm blocking the pelvis so he's not compensating from the hips, then you put more stress through thoracic spine. So if you rotate with the pelvis blocked and it's more pain, maybe it's more thoracic. If I'm blocking and it's rotating and the pain disappears, maybe it's lumbar. But so it's a bit of reasoning, but still we need to do more testing. Does that make sense? Yeah? Okay, I'll get you come into standing. Now, for very acute pain, and you know, they can't even, the minute they bend, or like in my case, let's do that. In fact, bending for me when I had acute back pain, it was perfect. It was relieving. The minute I extend, like literally muscle spasm and almost shooting pain in my butt. So I definitely got some disc prolapse there for sure, but it's touch of wood, you know, it's not touching my nerve. I'm not really kind of getting any leg symptoms, so you know. Although yesterday from walking, I did feel a little bit there, but it's anyway, so it's fine. So for me, flexion was a movement that I would start with to see if it's centralizing the symptoms. Because extension, it was worse. So the minute I do extension, it was getting worse. So I do like repeated movements because it gives you the direction of treatment as well. So that could be assessment, also treatment with Mackenzie. So let's go for example. So let's say you told me that extension is very painful. So let's do just relax waken, you come to flexion for me, and just repeat that for me a few times, okay? And come back up. Just go where you're comfortable. So patient does that, yeah. And I can just want to say, so how is that feeling even during movement? Or in fact, it's easing. So if you said it's easing, that means I'm gonna involve this movement in my acute management of a lumbar pain. But for some people, that could peripheralize symptoms, make it worse. So then you could do repeat extensions. So repeat extensions, I do like a bit easier, so I'm gonna go to do this wall. I get the patient to kind of stand against, like that, and I say, you just drop your pelvis forward 10 times and see what happens to your spine. Or to your back pain or even leg pain, to be honest, in another acute setting. So drop your pelvis forward. No, just relax and just drift forward, yes. So that's hip and lumbar extension, isn't it? Come to neutral, good. Good, and see what that does. If that is better, centralizes pain, feels nice to the patient, that maybe would be my acute management. Repeated extensions, like Mackenzie, isn't it? But thank you. So, but for some people it's worse. So literally, like I was giving an example, if I did repeat extension, that was getting worse. Repeated flexion for me was better. So patient tells you, you observe them how they do this, and then you just gather that information. So I'm still gathering information. Any questions, guys, on that? I know you've done that many times, but I think it's just about maybe interpreting those findings and what you're looking for. So we're looking for, is it a stretching pain? Is it more compressive pain with these movements? And also in the acute setting, you can do the repeated movements as well. How does that sound? All right, let's have a go on each other, okay? Repeat movements.